So first, Dr. Joshi, I'm glad you didn't truncate your talk too much. I really enjoyed it, and it was a privilege to listen to you. Thank you so much. And thank you to Dr. Suresh and her colleagues for inviting me to present this afternoon. As I've said in the chat room already, I only regret that I'm not there in person because I truly love visiting India. So I will not detain you very long. I'm going to show a few slides. I'm going to look at some of the questions that I think may be relevant as a fellow clinician to your daily care of patients. You may not agree with my thoughts, and I'm happy to be challenged and even to change my views if you can persuade me. So I'm going to ask, as I say, a series of questions, and I hope that I can give clear answers. I'm aware that India had a new set of guidelines last year, and I think they are excellent. I may allude to some of them in the areas where I think it's in interest. So I think the first question is when to treat. And I think it's quite interesting that with the development of a large number of very efficient, very reproducible, very accurate semi-automatic devices, we should move the diagnosis of hypertension more into the community and empower our patients not only to help us in making management decisions, but also in monitoring their blood pressure control. Now, of course, above 140/90 in the office is not the same as at home or on a 24-hour ambulatory study. So we have to bear in mind that the diagnosis of hypertension is on a lower level of blood pressure when the patient is making the measurements themselves. And of course, as I'm sure this highly knowledgeable audience is aware, the Americans have actually clouded the system slightly with the unattended office blood pressure monitor. But it's important to bear in mind that hypertension unattended in the office will be above 135/85. And basically, once we have achieved these levels and above, we've got to consider a treatment regime. Now, these are the European guidelines, and as Dr. Joshi has just mentioned, I was the co-chair of the Guidelines Review Committee. It took a very long time and a great deal of argument to come to a consensus about guideline management in 2018. And here we have what we arrived at after really considerable fighting that went on between the review committee and the writing committee. Your optimal blood pressure in the office, bear in mind this is in the office, should be less than 120/80. Your normal blood pressure is 120/129. Your high normal is 130/139. And hypertension, as I've already indicated, would be 140/90. If you're in these three categories, you're just going to have your blood pressure monitored. Actually, if you're above or you have a level of 140/90 or above, then we have to look at what guidelines tell us. In actual fact, the European guidelines suggested repeat visits. The British guidelines actually suggested no more repeat visits, but we should monitor the blood pressure either at home or over a 24-hour period to establish a diagnosis, bearing in mind the blood pressure must be above 135/85 on average. The NICE guidelines, again, as I said in Britain, again suggested if you have any casual blood pressures in the office between these two levels, then you should actually go into the community or get the patient to measure the blood pressure themselves. And here are the office blood pressure thresholds for drug treatment. Under 65, above 140/90. 65 to 80, above 140/90. Over 80, above 160. Or if there is a very high cardiovascular risk profile, you might consider lowering your threshold for treatment in order to protect the already damaged circulation. The second question is, how should we treat our patients? I'm aware of the Indian guidelines, and I think they largely accord with the European ones, and I think that the British guidelines will ultimately move towards where you are and where the Europeans are. If we summarize, we will have our lifestyle interventions, we will have drug treatment strategies, and we should address whether we should consider using device-based therapies. I'm going to really look at these two areas in a bit of detail. So the second part of this question is, are all antihypertensive drugs the same? I'm mindful of what Dr. Joshi has just told us, so I'm going to look at blood pressure control. Now, this question has been addressed in 5 different analyses. I'm just going to show an example of one of these, which is nearly 20 years old. So this is a study which looked at 9 trials of mild to moderate hypertensive treatment, which included nearly 63,000 patients. And it concluded that older drugs, such as thiazide-like diuretics and beta blockers, provide similar protection to ACE inhibitors and calcium channel blockers. The most recent analysis has also included angiotensin receptor blockers in this as well. And it drew our attention to the fact that any differences in outcome on trials can be attributed to achieved differences in systolic pressure. And what this means is, if you've got a randomized trial of thousands of patients, and some of them are randomized to drug A and some of them are randomized to drug B, the average blood pressure on drug A may be slightly different to that achieved on drug B. And if we don't take that into consideration, it's all too easy to say that drug A is better than drug B and not look at what achieved blood pressure was actually made in the trial. So the answer to this question, when you're selecting the treatment for your patients, is it's not the drug you prescribe, it is the achieved blood pressure that is important. This means that clinicians who obviously know their patients best will select what they think is the ideal drug for that individual and make sure that the blood pressure is well controlled. And I'll come back to the targets for blood pressure control at a subsequent question. So my third issue is, if you've got a patient whose blood pressure is not controlled, what is the drug of choice for resistant hypertension? And we do have an answer to this. It came from a trial which is now 4 or 5 years old, but gives us an unequivocal answer to the question. This would be for our 4th line drug in the management of hypertension. And it's important that we address this question in advance at looking not only at targets, but how to start drug therapy in our patients. So here are the data. They come from a study called Pathway 2. And the background to this trial was that resistant hypertension is defined as uncontrolled blood pressure despite treatment with maximum tolerated doses of 3 drugs, usually an ACE inhibitor or an angiotensin receptor blocker, plus a calcium channel blocker and a thiazide-like diuretic. And the optimal drug treatment of resistant hypertension remains undefined. There have been no randomized controlled trials directly comparing aldosterone antagonists such as spironolactone with other drugs to determine whether spironolactone is the most effective treatment for resistant hypertension. And the hypothesis that was tested was that further diuretic therapy with spironolactone will be more effective at lowering blood pressure than alternative blood pressure lowering drugs. So I can now switch straight to the results which give an unequivocal answer to this question. Here are the blood pressures, systolic measured at baseline and at the closeout of this study. And we have placebo, bisoprolol, doxazosin, and spironolactone. And there is no doubt whatsoever that the most effective fourth-line drug is spironolactone. I know that a lot of people have reservations about this agent. There are two things to say. In a low dose, side effects in males will be minimal. Second, that there are alternatives. And at the American Heart Association upcoming, the data from the Fidelio study will be reported, which will give us yet another aldosterone antagonist. So now let's look at starting treatment in our hypertensive patients and the European approach to improve blood pressure control, which I think largely agrees with the guidelines in India. So the first thing to do is to consider starting treatment in most patients with 2 drugs, not 1. We must be mindful of the fact that monotherapy is usually inadequate for most people, and an initial therapy with a combination of 2 drugs should now be considered usual care. And here are data to support this. These are combination therapy being superior to sequential monotherapy for the additional treatment of hypertension from Tom MacDonald in Dundee, Scotland. The red line shows the fall in systolic blood pressure with the combination of the 2 drugs. And here you see the more gradual fall with the monotherapies, which would either be losartan or hydrochlorothiazide as monotherapy. And you can see these data in terms of responder rates throughout the combination. Is going to control between 75 and 85% of patients before we even think about adding any other treatment. Also, we should bear in mind that there are dose combinations, and a single pill strategy to treat hypertension is preferable because poor adherence to antihypertensive drugs is directly related to the number of pills and is a major factor contributing to poor blood pressure control rates. I aim to return to this very briefly in this presentation. Single pill combination therapy is now the preferred strategy for initial 2-drug combination treatment of hypertension and for 3-drug combination therapy when required. So these are the European recommendations for uncomplicated hypertension and most patients with hypertension-mediated organ damage, cerebrovascular disease, diabetes, or peripheral arterial disease. So we begin with 1 pill, which would be an ACE or an ARB plus a CCB, or ACE or ARB plus diuretic. We can also go to 1 pill if we need a triple. That'll be an ACE or ARB plus CCB plus diuretic. And then, given what I've already presented, we can combine at step 3 for resistant hypertension, adding an aldosterone antagonist, or if you're not convinced, you can use the others such as loop diuretic, alpha blocker or beta blocker, and consider referral for special investigations. Bear in mind that we should use beta blockers when there's a specific indication, such as heart failure, angina, post-MI, atrial fibrillation, or younger women with or planning a pregnancy. And this is what we can achieve. Here's a 2-drug combination. This is olmesartan and amlodipine in low dose, increasing the olmesartan and then increasing the amlodipine to get control of 77% of patients. And if you go to the triple, you can get up to 90% control just with a single tablet. Now, what is the treatment target? Now, many physicians have been concerned about the data from the SPRINT trial and lowering blood pressure too far and doing more harm than good because of the so-called J-curve association. Here is data that Dr. Joshi alluded to from OnTarget and also from Transcend. Here is achieved systolic blood pressure, and here is the primary outcome, which of course is a combination of a variety of circulatory problems. And you can see that as we lower the blood pressure, we reduce the events, but if we go too low, there is an increase in events. Let's just bear in mind that the optimal treated systolic blood pressure appears to be between 120 and 140. There is a signal of increased risk when the treated systolic blood pressure is less than 120 millimeters. So that leaves us to find a target between 121 and 139. These are the achieved diastolic data from the same trials. And in summary, optimal treated diastolic blood pressure appears to be between 70 and 80 millimeters in patients treated to an optimal systolic pressure of between 120 and less than 140. There is a signal of increased risk with diastolic pressures less than 70. And that's associated with the most noticeable rise for MI and heart failure hospitalization. Now, before I give you the targets, which look largely the same now globally, we've got to bear in mind the concept of a target range for blood pressure in patients with treated hypertension defines the level of blood pressure to aim for with treatment with a lower safety boundary for systolic and diastolic blood pressure. May I emphasize the priority is to control systolic blood pressure. Do not compromise the lowering of systolic blood pressure if the diastolic blood pressure is below the optimal target range, unless the patient has symptomatic hypotension. For patients who achieve systolic or diastolic blood pressure levels below the target range on treatment, monitor for tolerability, but don't necessarily reduce treatment if the patient is asymptomatic, especially in younger patients. So here are the targets that I've selected. The Americans, as you are aware, have gone down to less than 130/80. The Europeans decided not to do this, but to go for a target of less than 140/90. But if the patient is tolerating therapy well, you could consider going lower. The UK has stuck at less than 140/90 and a slightly higher systolic if the patient is over 80. India has gone for 130/80, which I think is because of the American data and the American guidelines. Canadians have gone to less than 120, the only country of which I'm aware. And because I've been lecturing in the Middle East, I just thought I'd put that in the Middle East, it'll be less than 140/90. It's important for me just to make one observation before moving to the next question, and that is that the Europeans decided not to go to 130/80, as did NICE, because SPRINT excluded patients with previous stroke or diabetes, and therefore you could not extrapolate generally to all hypertensives with a single guideline, with a single target. Just 3 questions to briefly address now. Does resistant hypertension truly exist? This is a very interesting question, and what we have done in my clinic is stop investigating patients for secondary forms of hypertension until we have screened their urine for 50 commonly prescribed antihypertensive drugs. Here is the example that I give. This is a lady who is supposed to be on losartan, atenolol, diltiazem, doxazosin, bendrafluozide, and spironolactone. This patient is an example of many that are referred to my practice. Please control this lady's blood pressure. And the diagnosis is one of non-adherence. And this is a major, major problem. Here are data from Professor Tomaszewski's clinic in Leicester. This is 208 patients, and you can see that there is 25% of these patients are either non-adherent or partially non-adherent. And over here, we have patients referred for renal denervation, and 24% of them have been considered for device management when all we needed to do was to make sure that they took the drugs. I also should make one other observation. This is not just germane to hypertension. It's also seen in chronic diseases such as rheumatoid arthritis and asthma. So these are major issues for treating chronic disease. Seventh question is, should we use devices to lower blood pressure? And the answer to this question in 2020 is no. We have data on renal denervation from Simplicity 3, and here we have the definitive answer. This is renal denervation with a systolic fall in blood pressure of 14. Here is the sham with a systolic fall of 12. And this actually drives a stake through the heart of device management. Now, I acknowledge that we have newer catheters which allow more applications to the wall and are going down to lower branches, and the data are beginning to look interesting. Here we have renal denervation. This is the sham. You can see a genuine fall in blood pressure, both in systolic and diastolic compared with the sham, but bear in mind that these falls are relatively small, and that means that the patients are still going to need to take drug therapy, and also that there are new data suggesting that throughout the course of these studies, there is about an 80% change in adherence rates in the patients. So some of this may be as a result of improved adherence. I know that there has been a talk on COVID-19 and hypertension, so I'm just going to summarize my conclusions on this. ACE2 is the enzyme that physiologically counters renin-angiotensin activation and is the functional receptor for COVID. Select preclinical studies have suggested that RAS inhibitors may increase ACE2 expression, raising concerns regarding their safety in patients with COVID. Insufficient data are available to determine whether these observations are translatable to humans. Clinical trials are underway to test the safety and efficacy of these modulators, but the trials that have been reported retrospectively now are all negative. There is no evidence that there is a severe COVID infection in patients on ACE or angiotensin receptor blockers. The abrupt withdrawal of RAS inhibitors in high-risk patients, including those with heart failure or have had myocardial infarction, may result in clinical instability and adverse health outcomes. And until further data are available, we think that RAS inhibitors should be continued in patients in otherwise stable conditions who are at risk for or being evaluated for or with COVID-19. And there I shall stop, and thank you so much.